Gago.
Third year running, the dubious honor of being the complications expert. I'll title this talk Complications in Hip Arthroscopy, and more importantly, how to avoid them. Disclosures, fellowship support from Hinsdale Hospital Foundation, research consultant, fellowship and miscellaneous support from Arthrex, research and fellowship support from Mako. This is a summary slide of three of the major publications on complications in hip arthroscopy, including 1,000, 1,500, and 500 patients respectively, two of the authors being here on the panel, Drs. Bird and Sampson. And this is a very exhaustive list in the left-hand column of all the complications that can occur. Dr. Elizabeth Turi, to my left, also described complications of FAI surgery in 2009, so we have a lot of expertise on this panel. I'll try to divide the discussion of complications into complications you can avoid, complications you can minimize, the rare but terrible, and a quick discussion of the safe technique to avoid them all. So complications you can avoid. This may include articular cartilage scuffing, labral penetration, anchor penetration of the cartilage, and under-resection or over-resection in FAI. Cartilage scuffing is probably underreported. It's frequently seen in revisions, and avoiding scuffs includes ensuring proper distraction, using a safe access technique, which we'll discuss a little bit more later, and maybe most importantly, using a light touch throughout surgery. I think that as soon as we use force, we run risk of scuffing. Two-finger technique, two fingers of each hand should probably be enough to manipulate the instruments in your hands, including the camera, and that light touch will help avoid scuffing. Labral penetration. This is most commonly a puncture of the labrum with the first portal placement. One study out of the OSSM in 2009, subsequently published, demonstrated a 20% rate of labral penetration. In our consecutive series of 300 patients, we had less than a 0.1% rate of labral penetration. So I think a low rate of penetration is certainly possible, but only with care. And this is a common complication that needs some attention to avoid. Articular penetration with the anchors will probably lead to an almost certain poor outcome. Prevention includes use of multiple arthroscopic perspectives and visualizing the articular surface throughout the drilling and insertion. Now, in addressing FAI, if we address a cam lesion, we may under-resect, and if we under-resect, we leave residual impingement. However, if we over-resect, we may create loss of the suction seal by disrupting contact between the osteoplasty surface and the labrum. We may cause catching of a jagged edge of the osteoplasty against the labrum, and in the worst of cases, we may create an incongruent joint which does not function biomechanically the way it should. In treating a pincer lesion, again, under-resection will lead to residual impingement, but over-resection may at best cause iatrogenic dysplasia and at worst may cause iatrogenic dislocation, very dire complications. So historically, incomplete reshaping in FAI has been considered one of the most common reasons for revision hip arthroscopy, and this according to at least 3 different papers. Incomplete reshaping, I would put forth, is treatable in revision surgery because no major bridges have been burned. The bone is still there, so it can still be reshaped. In contrast, over-resection in FAI, I believe the pendulum has swung such that there is an increasing incidence in over-resection as more surgeons undertake FAI. In my practice, I believe this is now the most common, or one of the most common reasons for revision hip arthroscopy is over-resection. It's much more challenging to treat in the revision circumstance because bridges may indeed have been burned. This may lead us to the conclusion that we should consider erring toward under-resection or even not treating FAI at times rather than risk over-resection. So over-resection, this is a case of a 40-year-old male police officer. He has to be able to run to do his job. He underwent an arthroscopy with a femoroplasty, and this was his post-operative MR arthrogram after he had continued pain. So we can see there's a fairly clear, what we'd call an apple bite deformity in the femoral head, which is causing pain, causing catching, and probably causing disruption of his suction seal. How do we treat this? Our options may include a femoral head allograft through an open surgical dislocation to restore the congruity of the joint, or a total hip replacement. After being on a wait list for 5 months for a femoral head allograft, this gentleman opted for a total hip replacement. And we can see the area of the femoroplasty here. So that moves us along to complications we can minimize, including heterotopic ossification, DVTs, and neurologic injuries. Randelli at Isha in 2009 presented a 1.6% incidence of heterotopic ossification and stated that they occurred only in patients who had gone without prophylaxis. Here's an example of CT scan demonstrating fairly extensive heterotopic ossification, which is problematic in that patient. Prevention may include use of NSAIDs or aspirin, and maybe not spoken about very much in the literature, but probably important, is avoidance of bony debris from the resections by using a proper inflow-outflow technique. Neurologic injuries have a reported overall incidence of 1 to 2%. Most are temporary, but a permanent injury to a nerve is catastrophic, so it's something that I think we all fear very much. Prevention may include limiting traction time, use of a well-padded perineal post, and securing the feet in such a way that the forces are well distributed around the foot and ankle and there's no focal pressure on the superficial perineal nerve, for instance. DVTs and PEs, in one literature review, had a 0% incidence. That has not been our experience in Chicago. We've had about a 1% incidence despite using aspirin on all patients and using Lovenox on any high-risk patient. So I think it is present, not high, but certainly a concern, and would recommend use of blood thinners in any patient who is high risk. Now, the rare but terrible: femoral neck fractures, dislocations, intra-abdominal fluid extravasations. Femoral neck fractures may occur with over-resection of a cam lesion and may result from early weight bearing after femoroplasty. Iatrogenic dislocations, these can probably be prevented by avoidance of over-resection of the rim, by preservation or repair of the capsule, and by labral preservation, repair, or perhaps reconstruction. This x-ray courtesy of Dean Matsuda, who had the courage to present this case and has certainly made us all aware of this as a potential complication. Intra-abdominal extravasation is a potentially catastrophic event. I'm aware of at least 2 cardiac arrests that have resulted. Prevention includes avoiding hip arthroscopy and acetabular fractures, I think, at all costs, because the fluid can intravasate through the fracture line into the intra-abdominal compartment. Use of an inflow-outflow system, feeling the abdomen every 15 minutes, and frequently checking oxygenation with the anesthesiologist. Thank you to Dr. Sampson for those comments. Now, the use of a safe technique, Pete Myers went through a lot of this very early, and I think he and I learned much of what we know about it from Dr. Bird, so very common approaches in how we enter the joint. Positioning with a well-padded perineal post, protect the genitalia, limit your traction time to something. You can talk to a few different surgeons and get different times. I used to use 2 hours as a cutoff. I went down to 90 minutes about 2 years ago as my cutoff, and have seen a decrease in neuropraxias since that time. So 90 minutes or 2 hours seem to be common cutoffs amongst many surgeons. When entering the joint, you can enter distal to the labrum and vent the joint and allow air to rush in. Minor difference from the technique Peter showed earlier. I don't inject fluid into the joint. The air actually allows me to see the shadow of the labrum in some cases, and it's the venting of the joint that gets more distension. I haven't experienced that injecting fluid gets us further distension, so we just use air. And then we pass the labrum with the flat part of the bevel toward the labrum, advance a couple millimeters and flip the bevel so that the bevel is now toward the femoral head, and we pass the femoral head, thus minimizing risk of labral penetration, minimizing risk of femoral head scuffing. Guide wire through the spinal needle, trocar over the guide wire, levering away from the femoral head as we enter. Plan your bony resections preoperatively. I would recommend extensive intraoperative fluoroscopy, especially if doing bony resections in FAI. I would advocate repair of capsulotomies routinely, except in cases where we think the capsulotomy is itself therapeutic. I think we could consider putting it back where we found it. First, do no harm. Perhaps it is better to ignore FAI than to over-resect. Dr. Bird gave us great results with 10 years follow-up in labral debridement alone. So if treating the bony impingement, be conservative and keep in mind that the hazards of over-resection are probably greater than the hazards of under-resection. We looked at the learning curve in hip arthroscopy, prospectively studied 355 hip arthroscopies and found significant improvement in all outcomes. There was a gradual decrease in the complication rate and an improvement in outcomes after 200 cases. So consider in hip arthroscopy the learning curve is steep. It's probably not a great surgery for dabbling. Who knows what the learning curve is. We can find a few different data points. Specific training in hip arthroscopy is certainly available and I would say beneficial, and with such training I think most complications are certainly avoidable. I would leave you with use your resources. There are fellowships which have a component of hip arthroscopy or are dedicated to hip arthroscopy. There are many fellowships, extensive courses and surgeon observations, and maybe most importantly of all, it's important to have friends and people you can call who have done a bunch of hip arthroscopy, who you can compare cases with. Certainly anybody on this panel I think would be open to that. Thank you very much.